Do you hear me?
Yes.
Yes. So I'm Dr. Otto, as the Dr. Gia mentioned, and I will present this case today. Thank you again, once again, for inviting us. As we all know, SLC 6A1 is mostly associated with epilepsy, especially myoclonic atonic epilepsy. However, but of course, other epiphenomena are frequent as well. For example, ataxia, movement disorders, so on. But we have observed a very peculiar case where there are no signs of epilepsy, neither semiologic, neither clinical nor electrographic. And this case most likely represents a spectrum of episodic ataxias, as they call it historically. The patient is a 7-year-old girl who was born at term after an uneventful pregnancy. Developmental milestones met until the age of 2. And no family history with no family history of any disease, any genetic disease, of course. The patient had in general 5 severe and weekly short-lasting attacks. Each attack was preceded by anxiety or emotional stress, and every attack was the predominating symptoms in every attack was cerebellar syndrome, including dysmetria, strabism, dysarthria, and symptoms like mydriasis and unsteady gait. The bigger or the more severe attacks were lasting for several days, sometimes even weeks, and the recovery was gradual, sometimes leaving some residual ataxia or unsteady gait over a period of several weeks, but eventually the child returned to the baseline. And the relatively shorter attacks, which were much more frequent, of course, were associated with mild dysmetria and dysarthria. We did initially the child was diagnosed with encephalitis because the condition was pretty severe. The child was the consciousness was decreased and so on. The extensive testing included the lumbar puncture for autoimmune encephalitis and the infectious causes, CBC serology, and so on. We did brain MRI as well, which was negative. Eventually, we performed the whole exome sequencing, which identified pathogenic variant in SL6A1 gene. The child initially was treated with anti-seizure medications, including clonazepam, valproic acid, lamotrigine, and oxcarbazepine, which did not have any effect on the child. These episodes continued. Now, but after the child was admitted to our hospital, we questioned the diagnosis of epilepsy. Because for us, the clinical manifestation of the patient was more similar to the episodic ataxia, like, for example, CACNA 1A. We initiated, due to this resemblance to the episodic ataxia type 2, we initiated acetazolamide, 250 milligram per day, which resulted in complete remission of attacks, and the baseline ataxia was improved as well. It is already 18 months since we initiated acetazolamide, and there has been no attack whatsoever until now. And the baseline ataxia also is also improved. We have reduced the doses of anti-seizure medications, and now the child receives only acetazolamide. This case is peculiar to 2 reasons. First, I think this is the first time when such type of phenotype is described in the context of SLC 6A1 pathogenic variants. And the second is that, as far as I know, there has been no report of positive effect with acetazolamide in SLC 6A1 pathogenic variant. Yes, Dr. Gia, do you want to add something?
We found out that there are subset of, let's say, monogenic disorders which could be dramatically responsive to acetazolamide, and prototype could be SCN1A gene. And because our patient phenotype closely resembling of CACNA1A episodic ataxia type 2, And the phenotype of our patients stands out of phenotype previously described in SLC6A1. And we are proposing that first, if there is other patient with such a phenotype, without epilepsy, without any signs of epilepsy, any semiology of epilepsy, without EEG, epileptiform discharges, it would be nice to collect such a patient if they exist. And we think it would be nice to do trial with acetazolamide with such a patient, because acetazolamide is approved by FDA and in Europe, and there won't be any regulatory issues. And we believe patient, at least with such a phenotype, would benefit from this cheap and very easily available drug. And recently we published paper in Epilepsy Open about effectiveness of acetazolamide in CHD2 related epilepsy. And at some point, phenotype of CHD2 related epilepsy resembles those of SLC6A, especially both epilepsy predominantly have myoclonic seizures. And that's all. First, we wanted to share our case with medical community and parental community. Second, we would like, if there is another patient with such a phenotype, so phenotype of episodic crises resembling episodic ataxia, and without EEG, epileptiform discharges. And we will be happy to have possibility to hear about if there is such a cases. We believe it worth to try acetazolamide. That's all so far. Should you have any question, we would be happy to answer. And thank you, Amber, again, for giving us opportunity to share this case with you.
Carrie Jo?
Yeah.
Yeah, maybe I missed it, but what made you think about using acetazolamide for this person?
The clinical features of this patient resemble the episodic ataxia type 2, the one that can be caused by pathogenic variants in CACNA1A mutations.
Yes. At second, acetazolamide recently in August, our paper on CHD2 related epilepsy and acetazolamide was published in Epilepsy Open. And those two conditions share predominant type of seizures, you see, myoclonic seizure in CHD2 related epilepsy and myoclonic seizures in SLC6A1. And also ataxia also is, let's say, symptom could be very often seen in both conditions.
Okay, awesome. Oh, we'll take Dr. Rogowski's question and then we will move on to scientific, and I'll send out an email with everybody on this.
This is really an interesting observation. Thank you for sharing that. I noticed that you didn't try topiramate as one of the anti-seizure medications. And as you know, acetazolamide is a carbonic anhydrase inhibitor. That's how it acts. Topiramate also has carbonic anhydrase inhibitory activity, maybe not as strong as that of acetazolamide, but it nevertheless has it. And I'm wondering whether you have any experience with topiramate, either in the episodic ataxia cases or here in SLC6A1, and perhaps others who might have tried topiramate in the seizures. Have there been any successes there?
Thank you for great question. We have not used topiramide in our case, and of course there is a class of anti-seizure medication which with inhibitor, carbohydrate inhibitor. However, again, we copy paste, let's say, because in episodic ataxia type 2, second name of this ataxia is acetazolamide responsive ataxia. That was the reason we started with acetazolamide, because of very close resemblance of phenotypically of both conditions. However, you are right. There are a class of anti-seizure medication like zonisamide, sultiam in Europe, topiramate, and acetazolamide, which are mode of action. However, I don't want to go deeply, but when we have searched a literature about inhibition of carbohydrates, there are some papers telling us that even without moiety its molecule has a moiety which are responsive for carbohydrate inhibitions. This drug, especially acetazolamide, could work even with the same efficacy without this moiety. I don't know why. That is a question to the basic scientists, to the physiologists, pathophysiologists, but I don't know why. However, I try to explain why we choose acetazolamide, just simply because of resemblance of episodic ataxia type 2, which so-called acetazolamide responsive ataxia. That's why we choose first acetazolamide. And again, in our cases with CHD2 epilepsy, we don't have explanation there so far, but acetazolamide was much effective. Even zonisamide was not effective in CHD2 related epilepsy. We tried in several patients. Topiramide was not effective in our patients with CHD2 epilepsy. So in spite of fact that there are similar class of medicine, I think the mode of action could be at some point different for that drug. But I don't know so far, and there should be input from basic scientists, let's say there should be done patch clamp studies, animal model studies, but I think it's future directions. Sorry for long explanation.
Yeah, very interesting. So you're proposing then that acetazolamide might act in some way apart from its inhibitory effect on carbonic anhydrase.
Exactly. Yeah. And there is clear that acetazolamide is a multifaceted drug. You see, it could work on, let's say, BK channel. BK is big, large conductance potassium channels. It could work on R-type channels expressed mainly in neocortex. It could work on acid sensing ion channels. And also recent publications tell us that it could work on even on agapurines. You see, agapurin, especially 4. But there is future. It's let's say a lot of things. I think we believe a lot of things should be done, must be done to explore its exact mode of action. Because we are. Thank you, and sorry again for very long explanation.
But we should point out that Sandy has made a note in the chat that her daughter was tested with topiramate and it didn't provide full seizure control. I assume Sandy's daughter has SLC6A1.
Yeah, that's the story was in our CHD2 patients. Exactly. We used topiramide for a couple of our patients with CHD2 was, and we were unsuccessful. And the same story was with zonisamide. But acetazolamide worked very well, worked dramatically for the same patients. I don't know the reason. I have no explanation. Just we can speculate, and there is some assumption.
Terry Joe,
Yeah.
with
I have a quick question. The SARA scale, the SARA scale for ataxia, is that clinician entered only, or can that be entered by caregivers?
What do you Otto will answer.
No, it was done by us. It was done by us, not the caregiver.
Okay. Do you know if it's possible for caregivers to complete the SARA scale, or is it only possible for clinicians?
For us, for the accuracy, I think it would be better if a doctor performed this test. However, I think the questionnaire itself is very easy, very understandable. So caregiver could also do that, but it would not be as reliable as if a doctor does it, of course.
Thank
We
you.
have done SARA test over during every follow-up visit.
And let's, if this test is properly explained to the caregiver, we don't think it will be hard for caregiver to fill it out.
okay, we need, did you start this drug along with clonazepam or valproic acid?
Sorry, Amber,
Do you see the question in the chat?
in chat.
Mm-hmm. Was the initiation of this drug done in parallel with?
Can we stop the sharing the screen, because here we see the chat. Okay.
Okay.
What was the mutation? Was the initiation of acetazolamide done in parallel?
We start acetazolamide with oxcarbazepine in combination with oxcarbazepine.
Okay.
Not with other medication, you see?
Okay, we will have more time at the end. I just want to make sure that Nanian has plenty of time to present. The second half of the lab meeting will be handed off to Rocco Zerlati. And Rocco, go ahead and you can share your screen.
Yeah.
Oh, and let me start recording. All right, I'm going to stop and start again.